Hello and welcome everyone. My name is Susan Hearns, CEO of Germane Solutions, and I'll be the moderator for today's webinar, Optimizing Your GME Footprint, CAP Strategy for Long-Term Impact. During today's webinar, we'll analyze how GME CAP strategy and program distribution influence long-term financial performance and institutional growth. We'll identify opportunities to optimize resident and fellow complement across programs to better align with workforce and community needs. Evaluate under or over cap positions and assess strategic options for program expansion and redistribution, and apply a strategic framework to support proactive GME planning and reduce financial and operational risk. Before I introduce today's speaker, there's a few administrative items to note. Participants have been muted upon entry to the session. If for any reason your audio is showing as unmuted, please mute yourself to eliminate background noise during the presentation. We've made every effort to reduce technical issues. If you have problems, please indicate them to Hunter Rich in a private chat. The slide presentation and the webinar broadcast are provided exclusively for the use of registrants and should not be shared. Reproducing, distributing, or transmitting any session materials of the live presentation to any group or individual requires express permission from Germane Solutions. If you have questions throughout the session, please submit them in the chat feature. We encourage you to ask your questions as they come up, as well as during dedicated question and answer time at the end of the session. If we cannot get through all the questions in the allotted time, or if you have a question that you don't want to share publicly, please submit them via email afterwards to Hunter Rich. Every registered participant for the session will receive an email containing a link to a survey so we can obtain feedback about the webinar. The survey is brief and we encourage your comments. Now let me introduce our speakers. Scott Masin and Kauser Siddiqui. Scott is a director at Germane Solutions and brings over a decade of healthcare and GME experience to today's conversation. He provides extensive experience and passion for financial accounting of GME operations and system strategies. Scott also specializes in partnering with institutions to provide initial feasibility assessments, new program applications, and the development of system affiliations that maximize reimbursement for health systems. Kauser is a senior consultant at Germane Solutions and specializes in GME finance and strategy with expertise in GME cap building, financial modeling, and developing long-term projections to assess the feasibility and sustainability of new residency and fellowship positions. Kauser's background also includes ACGME accreditation support, GME system strategy, and analyzing hospital and clinical data to guide decision-making at both the institutional and program level. Together, Scott and Kauser bring deep expertise in GME finance and system-level strategy, with a focus on helping institutions make strategically informed decisions about program growth, cap utilization, and long-term investments in GME. Their work centers on aligning financial performance, regulatory constraints, and organizational priorities to ensure that GME expansion and restructuring efforts are economically sound, strategically positioned, and sustainable within the broader health system landscape. Now let me turn the session over to our speakers. Kauser, you may begin.
Thank you, Susan. So how caps are actually set is one of the most important and often misunderstood aspects of GME strategy. At a high level, cap setting isn't something that just happens automatically. It's triggered by specific events, and how you structure your programs early on has long-term financial consequences. So as we go through this, I want you to think less about compliance and more about strategy, because this is really where organizations either lock in long-term value or leave money on the table. So the most important takeaway on this slide is that exceeding 1.0 FTE is the trigger that starts the cap development period. However, not all residents count the same way, depending on where they come from and how long the program has existed. If residents rotating to your hospital are from a new program, meaning the program is less than 5 years old, and you exceed 1.0 FTE, that will trigger both your FTE cap development period and your per resident amount, or PRA base year. In contrast, if those residents are from an established program, meaning a program more than 5 years old, exceeding 1.0 FTE will not trigger your cap development period, but it will establish your PRA base year. So that distinction is very important because a hospital's per resident amount, or PRA, is a key driver of the direct graduate medical education or DGME reimbursement. And once your PRA is set, it's set in perpetuity. So hospitals need to be very intentional here because once you trigger your cap, the clock starts and you have a limited window to build your long-term funded positions. Another important regulatory update to be aware of is that the mere presence policy has gone away. Historically, hospitals could receive cost-based reimbursement for partial year resident training below 1.0 FTE. Under the current rules, that flexibility no longer exists. The 1.0 FTE threshold is now the clear trigger for cap development period. But once your cap is triggered, that cap is triggered, hospitals enter a 5-year window to build their Medicare-funded cap. So however, how that cap is developed varies significantly depending on whether a hospital is classified as urban, rural, or rurally reclassified. So starting with urban hospitals, they have a single 5-year cap development period. That means all programs must be started within that window to build cap. After that cap period ends, adding new programs will not increase the hospital's cap. Once that cap is set, it's set for a lifetime. On the other hand, rural hospitals operate much differently. Each program has its own 5-year cap development period, which allows for staggered growth and significantly more flexibility in how cap is built over time. And then lastly, rurally reclassified hospitals. These hospitals present a unique strategic opportunity because they can leverage elements of both urban and rural cap development models. For a non-teaching rurally reclassified hospital, there is an initial 5-year cap development period where all programs started during that time will build both direct graduate medical education, or DGME, and indirect medical education, or IME cap. So very similar to an urban hospital. Once that initial 5-year period ends, the hospital begins to function more like a rural hospital. So at that point, new programs can still generate additional cap on a program by program basis, but only IME cap, not DGME. So both rural and rurally reclassified hospitals can have multiple concurrent cap development periods for each program. So here we have an example that shows how the maximum allowable cap is actually calculated. So in year 6, CMS will look back at the prior year and identify the PGY level with the highest number of filled FTEs. Then they multiply that number by the program length to determine the maximum allowable cap. So in this case, in this example, the PGY1 or PGY2 class in year 5 has 10 FTEs. And with a 3-year program, that results in a maximum allowable cap of 30. So what's critical here is that you only need one PGY class to be fully built out to maximize your cap. So even if another class, like PGY3 in this example, it's slightly underfilled, it does not reduce the overall cap as long as another level is fully populated. The second key point is that cap is distributed across hospitals based on the percentage of time residents train at each site over the entire 5-year period. So that means rotation design directly impacts how funding is allocated, not just where residents are physically located. Here we highlight the financial distinction between residents and fellows, specifically related to the initial residency period, or IRP. So residents training within their IRP generate full DGME and IME payments, but once physicians move beyond that period, so into fellowship, they are considered outside the IRP and generate only 50% of DGME reimbursement. So when you look at total reimbursement, that effectively translates to about a 1/6 reduction overall. Most importantly, IME remains fully intact. This is a common misconception. Many assume that both DGME and IME are reduced, but in reality, only DGME is impacted. From a strategic standpoint, fellows do still provide significant value. So while there is a reduction in DGME, that is often offset by clinical productivity and service line contributions. So it's important to consider the overall value of a fellow brings compared to a resident when evaluating program mix and growth for your institution. Now we're going to shift into one of the most powerful tools, I think, in GME strategy, and that's Medicare GME affiliation agreements. So this is where systems can start thinking beyond a single hospital and optimize across the entire network. So a Medicare GME affiliation agreement is a formal regulatory defined agreement that must include several key elements. It must have a minimum 1-year term beginning July 1st. It must clearly define each hospital's pre-affiliation cap, specify the adjustments being made, and identify all participating hospitals along with their Medicare provider numbers. Operationally, what this allows you to do is reallocate cap across hospitals. So you're not physically transferring residents, you're redistributing how those residents are counted for reimbursement purposes. So this becomes a powerful financial tool, particularly when there are differences in Medicare reimbursement rates across hospitals. It allows systems to maximize their total reimbursement. There are several compliance requirements that must be followed for affiliation agreements. First, the agreement must be submitted to the Medicare Administrative Contractor, or MAC, and CMS by June 30th, prior to the academic year. Second, there must be a shared rotational relationship between the participating hospitals. If the agreement is terminated, the cap reverts back to the originating hospital. So these arrangements are not permanent unless continuously renewed. And then finally, no resident can be counted as more than 1.0 FTE across all sites combined. So while these rules are relatively straightforward, failure to follow them can result in significant reimbursement issues. The recent CMS updates have expanded the ability to transfer newly developed cap through an MGME-AA. Historically, only pre-1996 cap could be shared. Now, newer cap can also be shared, but with timing restrictions. So after the 5-year cap development period, starting in year 6, cap can be shared with other new teaching hospitals within the same affiliated group. Then, after year 11, that cap can be shared with any hospital within the affiliated group. So this creates a phased approach to cap transferability, which requires long-term planning. But if structured correctly, it does allow systems to gradually increase flexibility in how cap is transferred across their network. Okay, so bringing this all together, affiliation agreements are a key tool for optimizing cap across a health system and addressing both operational and financial challenges. They enable coordination across multiple hospitals, support cross rotations within residency programs, and help balance situations where one hospital is overcapped while another is underutilized. From a system perspective, this creates alignment between training, workforce needs, and financial performance. So rather than leaving cap unused or carrying unfunded residents, hospitals can strategically redistribute capacity to maximize value. So ultimately, this results in more efficient use of Medicare funding and greater flexibility in designing programs that meet both clinical and educational goals. So it should be every health system's goal to utilize CAP as much as possible, and Medicare GME affiliation agreements allow you to do that. So next, I'll hand it over to Scott to walk us through program right sizing.
Awesome. Thank you, Kauser. Good morning or good afternoon to everyone on the call. I'll be going through a few slides here, kind of going through some strategic opportunities for program right sizing. We'll be focusing on just a few core concepts, as well as some focus areas for both new hospitals and existing hospitals. So looking forward to going through this with you all. As Susan mentioned at the beginning, if you guys do have any questions as we're going through, please feel free to submit them in the chat. We'll be happy to answer them as we move through or at the end. So please feel free to do that as we're talking. We can go to the next one, Kauser. All right. So one of the important concepts that we have is looking at the cap versus the count of an institution and or a health system. So most everyone is very familiar with the Medicare caps. So these caps were established back in 1996 when these were brought into effect, or they were built after the time periods that Kauser went through earlier in the presentation. And this is the limit that CMS will pay you in relation to the number of FTEs at your institution. The other important kind of the flip side of this is the count. And I feel like the count is a little bit less talked about in the world of GME. And for that specifically, the CMS always pays for, it pays at the lower of your cap or your count. So when we're kind of working with our different clients, we really view the cap as an asset. And if you're not fully utilizing your asset, there should probably be a good reason as to why you're not utilizing it. If not, you should be at or slightly above your cap just to make sure your funding is fully utilized from year to year. So that's kind of the main takeaway here. So if you have a cap set of 30 in this specific example here, you can train as many residents as you want over that cap of 30. You will always be funded at 30 residents. If you look at year 3 in this example, they dropped down to 29. The funding would slowly fluctuate down in that specific year. For those of you very familiar with GME funding, it's a little bit more complex to this with 3-year rolling averages, the intern and resident to bed ratio. But for the most part, this is a good way to guide at least that current year count to try to make sure that you're maximizing that on a year-over-year basis. Some of the other concepts here we'll be talking about how we kind of build on this for other opportunities. I have 2 questions. I have a couple questions in here. We'll see if we can go through these real quick to keep this a little bit interactive. It says, if a rural redesignated hospital partners with the THC GME sponsoring institution new program, can the rurally redesignated hospital claim those residents for time spending there and accrue new IME cap? So I think the main item here is that this is a new program. So for a new program, assuming for a rurally reclassified hospital, as long as it has a new accreditation, new program director, new faculty, new residents, it would be eligible to develop new IME funding. So there's a little bit more detail there. The one piece that, just to be clear, for the teaching health center GME funding, there's the one thing where it's the sponsoring institution. And if they're fully receiving funding from HRSA related to the THC GME funding, you can't double dip related to, if they have 15 residents in their program, you can't receive 15 FTEs of funding for that teaching health center GME through HRSA and then get another 2. So you basically get 17 funded positions for only 15 approved positions. So, but in general, yes, as long as it's a 10 and 5 split between the FQHC and the hospital. What is the typical proportion percentage of IME to GME? We normally describe it where it's about 2/3 IME and 1/3 GME. As Kauser was mentioning earlier, for fellows, you normally kind of negate half of the DGME funding. So we kind of say it reduces 1/6 of the total funding for an organization. That varies a little bit from place to place, but that's what we normally see for different locations. For slow community hospitals, just moving to the next question here. For slow community hospitals, I know we are limited on the IME based on the percentage of Medicare Advantage patients. What generally does the amount in comparison to the non-SCH rural classified hospitals? Good question. I mean, it really depends on the Medicare patient load. If we assume that it's a 50% Medicare patient population and half of those are Advantage patients, then that would knock out kind of half of those payments. I've seen it be very high and kind of 80% of the total IME payments. And I've seen it also be very low as far as 10 to 20%. I'd say normally it's probably around 30 to 40%, I think would probably be just from back of the napkin calculation. But the 30-40% would be reduced from the IME funding for a sole community hospital. But it is a variable calculation. Perfect. Appreciate the questions. Let's see. We got one more in here, and then we'll move on to this slide, and please feel free to keep adding them in. Regarding Medicare GME affiliation agreements, are there restrictions or minimums regarding the resident rotations between the two hospitals and affiliation agreement in order to share cap? So that's question one. In short, no, they don't have a specific definition, and we've kind of pushed CMS on this to say, is it a 1 point FTE? Is it a half an FTE? Is there a proportion to the number of FTEs we're transferring? There is not a specific amount there that we've been able to define or CMS has been able to define for us. In short, we just think it should be a scheduled rotation that's normally occurring. It should be easily definable to CMS or the auditors in order to demonstrate that there's a shared rotational arrangement. Question two, in order to establish cap through a Medicare affiliation agreement, must you have active rotations between the hospitals? I think what you're asking is, do you have to have one to that hospital and one back? And no, the answer is no. You just need to have a shared rotational. It can be either from one hospital to another hospital back, but doesn't necessarily have to be back and forth between the two institutions. We'll keep moving here, and then if we have time to come back for more questions, we certainly will. And I believe we'll have questions come back. So Caitlin will be sure to answer your question as well. So for cap development considerations, this is something that when we're working through kind of feasibility studies or trying to set kind of new teaching hospitals up for success, we need to be very strategic in those first 5 years of cap development. As Kauser was going through, 5 years for cap development is a very short period of time when you think about how long it takes to get programs started, specifically if you want to start multiple programs within that 5-year period. So one of our recommendations when we're going through this process is we want to be a little bit aggressive related to the number of programs we're starting in those initial years. We want it to be aggressive, yet we want it to be a smart approach to this, because we know at the end of that 5 years, that's what you're capped at for the lifetime of the hospital. If there's a way that we can go in this specific example, on the right, it has, we know that we want to operate the internal medicine program at 30 residents moving into the future. Like that's what makes sense for our institution. This is how we want to set this up. If you have the clinical capacity, if you have the physicians, if you have a lot of these different things, it may make sense to apply for a little bit larger program so you can then have cap after those 5 years of cap development to then use for other programs in the future. In this specific example, that's 15 FTEs here, but say you did a 39-person program instead of 30. It's not a lot larger, but those 9 additional FTEs, that could easily support a cardiology program or a GI program or a sports medicine program, whatever that may be. And we want to make sure we keep that in mind. We don't want to have just kind of our blinders on building these very large programs that really don't make sense, because the ACGME is going to be looking at what the clinical capacity is and if we can really support these long term. So One of the other strategic considerations that Kauser talked about a little bit earlier is there's also a little if you want to start a little bit larger program but don't think you can necessarily, it doesn't make sense operationally. If you get the accreditation for 45, you can keep 10 per year, and then in a year that makes sense, you can ramp that up for a year or two during the cap setting process in order to have a little bit more cap. So these are definitely items that are part of the decision-making process. We don't always just want to maximize everything, but we certainly want to have that lens when we're looking at this from a certain perspective, because if we don't, we certainly don't want to undersell the opportunities that we're going to have at this hospital long term to fund different opportunities that we're going to have in the future. I'll take a few other questions here. I know Caitlin promised you first here. Have you had experience with CMS taking away unutilized cap? Example, hospital expanded large in 5 years of large cap, but is not fully ready to expand our program service lines possibly in years ahead. Not necessarily back, I think it was in 2007, in the late 2000s, maybe early 2010s. CMS did go through and they kind of gathered up all of the unused cap at institutions across the country, and then they redistributed that to all the hospitals that were operating over their cap. So this is something that has happened historically. This isn't something that's slated for the near future from our perspective. It is something that could probably happen again, but there's not anything right now, or like CMS isn't able where like you were accredited for 40 or you have 40 cap positions and you're training 30 residents. There's not a time period where they're automatically going to come scrape that back, but they could do a larger national one like they did before. But that is, I've not seen anything like that being released or being talked about at a legislation level at this point. I'll do a couple of questions in the chat as well. How successful, or are there paths to success to get it reimbursed for non-ACGME but ABMS recognized fellowships? Many EM and FM fellowships are non-ACGME but recognized by other bodies. That's a good question, Nathaniel. There are avenues for funding for non-accredited fellowship programs. So it's more so on a cost-based reimbursement basis based on the Medicare utilization and respective units where the residents are training. It's a little bit complicated to go through and get that reimbursement through the Medicare cost report. There's a fair amount of documentation that has to be in place. There is an avenue for it, but you have to make sure you go through and have all the background information in order to go through that process. So the short answer is yes. The long answer is there's a fair amount of documentation that usually isn't available right now today that needs to be created to substantiate some of those reimbursement mechanisms. So I saw Caitlin's again. What happens to the building of a cap if a program increases the number of trainees year 3 in a 5-year program, and how is that reflected in the final cap development of FTE? Good question. As Kauser talked about on one of the earlier slides, when the cap is set in the 6th year, they look back at the 5th year. So in the 5th year of training, let's just say it's one internal medicine program with 5 residents per year. If they had 5 residents per year in that 5th year, in PGY 1, 2, and 3, it'd be 15. Even if they had, say, 3 residents in the PGY 2 class for any reason, your cap would still be set at 15 for that program. And the reason is they take the duration of training multiplied by the highest number of residents in that 5th year, and that sets your cap. So as I kind of alluded to a little bit earlier, you have the option to kind of wait and maximize your cap as it relates to the program. And you can wait till a little bit later in the cap development process and not have to have the full complement in your hospital. It could just be 1 or 2 years with that full amount. So I hope that answers your question. Okay, I think the same question is in there twice. So we'll keep moving here. So the last slide that was just talked about really focused on new program development. And I think this is a consideration that also needs to be done for existing institutions as well. So we kind of painted an example here on the slide. For some of you larger institutions, the 90-person internal medicine program isn't that outlandish. For some of the smaller community hospitals, this may seem like a very large program, but we can just look at the ratios related to this. But if for whatever reason it made a lot of sense to either start a 90-person internal medicine program back in 1996, or if it was a 60-person program and it's grown over the years through complement increases to meet the growing needs of the health system and or expansion of the health system. It's important to make sure that we're going back and reviewing why the programs are the size that they are. Are they giving us the value that we want? And is there another way that we could look at utilizing these assets that we have in the cap to maybe better meet the needs of our health system? And so in this specific example, or one of the common instances that we see is that, say, an internal medicine program is a little bit oversized because the ICU needs of that hospital are very complex and it's very busy, and we want to have consistent coverage in the ICU. Instead of having that program grow from 60 to 90 residents, you now have a cap of 90 to support this institution. Would it make sense to look at maybe some critical care fellowships that may be able to meet the needs of the ICU? It can provide a higher level of care. The residents can still get experience as needed. They can be training under a fellow, and the fellow can be providing some oversight for that resident. But it really can better meet the needs of the institution. So whether that be critical care medicine, pulmonary critical care, anesthesia critical care, I don't know if I'm missing any other there, but there's a lot of considerations there where just because it's been this way for 25 years, it may make a lot of sense to maybe take another look at this. And is there a way that we can kind of repurpose some of this cap to still provide coverage in the areas it's needed, still provide coverage to the inpatient departments, but maybe change how some of the care is delivered in, say, the ICU or maybe some of our subspecialty areas with some additional fellowships that are coming in. So this is traditionally something that's done over a multiple year period. We obviously don't want to negatively impact the residents that are training in the program. So if we want to, say, move to a strategy like this, this is where we would just recruit 3 less internal medicine residents in 1 year and start to decrease down the number of internal medicine residents we're training. And before we do that, we need to have the fellowship program accredited so then we can start recruiting those fellows in. So there may be a transition period there where you just have lower level fellows and you don't have kind of exactly what you need. But the goal is on kind of where we're going in the future, and does this better position us for success? So this is kind of one example with internal medicine, but this can certainly be done with a lot of specialties, whether that's surgery, whether that's anesthesia, whether it's family medicine. How do we provide the best care with the funding that we have from the federal government, and how do we redeploy that? The last thing I'll just say here real quick is Kauser talked about it earlier around the slide with the person and the half person. Yes, we do get slightly less funding with the fellows. We get half of the DGME or 1/6 less of the total. I do think it's important to consider the value that those fellows bring in relation to that small reduction in the funding from the federal government. So yes, there may be some unused DGME cap if you do a strategy like this, but the overall benefit that they're going to bring to the table normally far exceeds that small decrease in reimbursement. All right, so let's go through a few more kind of right-sizing considerations when we're looking to maximize the overall system value. I think I went through this in a lot of detail on the prior slide, but try to align the program size with the clinical demand. And as I mentioned before, just because we've had this program at 90 for many, many years, does this still meet the clinical demand that we have? Is there a way that we can repurpose this to maybe better meet our needs today and into the future? Optimizing Medicare GME funding. Kauser talked about this a little bit, but I think one of the pieces just to hone in on a little bit more is while the cap is a little bit synonymous and it's related to the number of FTEs that you're claiming at a respective site, and you can share that cap via Medicare GME affiliation agreements, the funding at these different locations is specific to the relative locations. So for 2 hospitals or 3 hospitals in a health system, the reimbursement can be very, very different when you look at these at different sites. So when we're trying to plan out a program, the education should always come first. We should make sure that we're looking at this to give the residents a great educational experience. But the financials definitely need to be a consideration when we're going through this as well, because if we can have a very similar type of experience at 2 locations that are both interested at training, and one gets reimbursed significantly more, that sets the institution up for a long-term viable program rather than one that may just be making ends meet and may not be giving the residents the facilities or the support that they need in order to make it a great program. So education and the clinical aspect of it should always be the first consideration, but there should certainly be a financial lens to it as well. Balancing the specialty mix across the system. I think that you all have probably heard about this in the world of GME. There's been a large focus on the need for more primary care doctors, more doctors in the rural setting, and there's been a fair amount of federal funding and grants that are coming out to support this as well. So this is something when we're thinking about strategic growth, is there a way that we can factor some of this in? Is there a way that we can help some of the rural communities, whether that's within your health system or not within your health system? Is there a way that we can help kind of develop some of these programs? And the funding for these is very beneficial too, because there's some additional restrictions, or there's less restrictions, I'm sorry, for some of these rural programs. If you're meeting 50% in a truly rural area and you're partnering with an urban site, you can actually create new funding cap that's separate and distinct from that 5-year cap development period that Kauser was talking about earlier. So it's certainly something to keep in mind when you're evaluating these strategic initiatives. And if there's a way to push more people into some of those primary care programs or into rural areas, it's certainly a great thing to consider. And then this kind of the rotations across system sites, this talks a little bit about earlier, what I mentioned earlier on this slide, but the affiliated sites, making sure we're looking at the different reimbursement rates. And if it makes sense, do we transfer cap from one site to another to help optimize the funding for the program, or have the residents training there from the very beginning in order to have the cap allocated correctly? It looked like one question in here from Dina, but with downsizing scenario, you get half the DGME. So we'd have to analyze how much indirect revenue generated by the fellow versus costing half the DGME. You said earlier that the IRP caps at 5 years. So you're saying the neurosurgery residents doesn't get reimbursed for year 6 and 7. So I think there's 2 separate questions there. So I think it's important to consider for the IME side of things, there's kind of 2 funding streams. There's the clinical funding stream for residents and fellows when they're helping kind of see patients and they're billing under a supervising physician. And then you have the other stream, which is from the federal government related to graduate medical education. We can talk about state funding as well, but we'll focus on these 2 today. So the indirect funding is coming to the residents for the training, which is separate and distinct from the clinical revenue that they're developing. So yes, we could kind of have a whole webinar related to the clinical reimbursement and how that reimbursement's coming in. But when the DGME is cut in half, that's a small portion of the total funding that they're getting from the federal government for graduate medical education training, separate and distinct from their clinical productivity. And let me know if I didn't answer that question as you laid it out. And then earlier, the IRP caps at 5 years. So you're saying that neurosurgery residents do not get reimbursed for years 6 and 7. Not necessarily in that 5th year, or maybe even another. I'll answer neurosurgery first. So in the 5th year of cap development, the cap is set in the 6th year. So in the 6th year, they look back to the 5th year. For neurosurgery, they would be in their 5th year of training. Assuming in that 5th year, they'd have PGY 1 through 5, presumably. They would take the duration of training, which is 7 years for neurosurgery, and they would multiply that by the highest number of trainees in one class from year 5. So if they had 3 residents per year in year 5, they would get 3 multiplied by 7, and then they would get 21 capped positions awarded for that program. It's And then the other thing I'll just mention is if you were to start, say, a general surgery program in year 4 of your CAP development period, just because we wouldn't have years 3, 4, and 5 within the CAP development period, you would still get the full funding for all of those positions, assuming that you have a full class in the year 5 of the CAP development period. So I think that's a very important strategic consideration, that during that 5th year of your CAP development period, you want to make sure you have those positions filled, or at least one class fully filled, because if not, you may be leaving some capped positions on the table. One more question here. Dr. Elway, is the reimbursement for non-ACGME but still ABMS recognized fellows still limited by the cap of the institution? No, it is not. It is completely separate and distinct, and it's actually done through a separate page on the Medicare cost report. So it is separate and distinct from the cap, and those FTEs aren't even kind of filled out on that portion of the cost report. Good question. All right, I think we can move forward here, Kauser. So the last kind of section that we have here is just around the program development considerations for sustainability. Obviously, there's a lot of different areas that we need to use, whether that's a rubric or whether that's a checklist. But for the most part, there's a couple ones that we'll focus on today. Now, from our experience in starting over 450 new programs, we've really found that these are some of the keys to success in areas where you really want to focus time and effort when you're looking at starting new programs. So we'll talk about these a little bit. It's not an exhaustive list, but at least some of the areas that we like to focus in on. So outside of specifically the ACGME requirements, because we all know that those are rather extensive for each and every specialty and a little bit different for all. These are 3 that we kind of outlined to talk about today. So robust specialty operations. So one of the questions that we get quite frequently, I'll pick on dermatology today. So we go to a specific location for a feasibility study, and we're talking to the leadership, and they're like, well, we really need more we need more dermatologists in this community. We only have 1. Let's start a residency program in order to get more dermatologists here. Some of the pushback that we have, the recommendations, and how we work through this process is we agree that having more dermatologists and training here, it higher the likelihood of them ultimately being retained here as well. But we need to have a very strong training environment for these residents and or fellows to get their experience. If we have 1 physician there, that's not a very stable area. We probably won't meet the ACGME side of things. But we're hoping that this could be a center of excellence or an area that the health system's investing a significant amount of money, or just an area that there's a lot of dedicated faculty that we can really kind of work with, and they're providing great care to the community. So even though some areas may very much be needed, but we want to make sure that there's a good training ground for the residents. There could be some exceptions here to this conversation around, say, a rural training program in a rural area where you may only need 1 or 2 physicians to help kind of facilitate an RTP or a 1+2 program. But even then, we've seen a lot of rural programs close because there's 2 physicians that are kind of facilitating the program. One of them retires, and then we don't have enough physicians there in order to keep the program going. So whenever we can, we want to make sure that there's a robust enough specialty operations in order to keep the program going long term. So health system / kind of hospital leadership and support. Obviously, graduate medical education is a complex endeavor, and there's a lot of upfront costs before you're ultimately reaping some of the benefits of these investments. So on the upfront costs, we have whether that's capital costs, renovations, equipment, a sim center, all these different things that it could be, as well as physicians that are there getting a paycheck and having protected time. And we don't get funding from the federal government yet until the residents start training. So there is an upfront cost related to getting these programs going. And we need to make sure that the hospital leadership is well aware of some of these costs and they can really buy in to see what the downstream benefit may be. So whether that's the financials or whether that's just getting them to understand the overall benefit of this is certainly something that's very, very important. And then lastly, physician support. So we've gone into a lot of different locations, and when we're looking at this, some physicians are very excited about the opportunity of graduate medical education, and some are a little bit less so. And depending upon how big of a priority this is for the health system, we need to make sure that we have ways to make sure that people want to stay involved. So whether that's the incentives, the compensation, whatever you want to call it, we know that physicians are going to want to be paid for their time when they're contributing to these graduate medical education programs. So when we're working through what does this look like, it's very different across the country. We want to try to align some of these incentive bases with kind of how things operate in different specialties. In some specialties, it may make sense. In some specialties, we may need to restructure how these incentives are set up in order to make people more interested. We want to have some commonalities between these, but there are some specifics between the different specialties. We've even seen it gone as far as, do we incentivize at the front end, going back to the significant upfront investment? Do we incentivize more on the front end until we have more senior level residents that can help facilitate some of the program? So there's a lot of different considerations there, but we want to make sure that the physicians are bought in. And if they're not bought in, how do we make them more interested in participating? Because without having a strong physician group participating, we're not going to have a successful program long term. All right, well, I believe that's in the slides. I'll turn over to Susan here, and then we'll make sure we get the rest of these questions answered before time is up.
Thank you, Scott. Thank you, Kauser. We have a couple questions in the Q&A section right now, but definitely the floor is open for additional questions from the audience. So if you want to put anything that you have into the Q&A box or into the chat, we can get some of those answered.
Yeah. So Dr. Carlson, when determining final overall cap, how does each distinct program involved in the cap 5-year cap growing time period contribute to this? Each program may have a different duration for a multiplier. Good question. So this is actually done on a program by program basis. So if we're assuming it's an urban non-teaching hospital that's going through the cap development period, you could have internal medicine, family medicine, and general surgery. Internal medicine and family medicine would both have a 3-year multiplier. General surgery would have a 5-year multiplier. But CMS is going to look, in the 6th year, they're going to look back at the 5th year. And for surgery, if it's 3 per class and they have 1 class with 3 residents, they would get 15 cap. Internal medicine, if it's 10 per year or 30 residents, it'd be 10 times 3. Then family medicine, we'll say it's 8. It'd be 8 times 3. So it'd be 24, 15, and 30. So those together would be the total cap that's assigned. So it is program specific, but that cap's all assigned at one time at the end of the 5-year period. Bethany, go ahead. Oh.
Just going to say there's a follow-up from Dr. McRae as well from the question you asked earlier. So you'd have to click on it. I can
I'll go down there. For Bethany, in a hospital that is in its cap development phase, could you explain how rotators from other established programs are considered in the cap build? Yeah, great question. So in the cap development period, you're only going to be building cap for the new programs. So let's just say we're doing internal medicine program 10 per year. You wouldn't ever be able to build a cap of 35 during that cap development period because you had 5 rotators coming in from another location. It's only related to the residents in the new program. So you could still claim those residents from the outside, but as we talked about a little bit earlier, you're going to get paid for the lower of your cap or your count. Unless you're getting cap transferred over to you for a Medicare GME affiliation agreement, you're still only going to be funded for the residents in the initial period there in the 5 years. And those 5 additional will be counted, but there would be no cap in order to receive the funding for those. All right, Dina, coming back to you. On another slide, it said the IRP is no more than 5 years. I'm not talking about building cap. I thought IRP covered the full length of training for residency programs. Yeah, the IRP does cover the full length of training programs, and for neurosurgery, it is 7 years. So if that was a typo on the current one, it could have been, but the CAP development process is 5 years, and I think neurosurgery may be the only exception to that. But they would still build the full CAP for those programs, even if they don't get the full training period within that 5-year CAP development period, as long as it's started and they have a full class. Confirming what I think I heard, if we have a new rural family medicine programs and we add a new surgery program at that hospital, in the CAP development year 5, the total CAP would be all the residents family medicine program plus the number of PGY residents multiplied by 5. That is exactly correct. So it's kind of strange. You'd actually have more CAP for a small period of time than the actual residents that you have training in the program. And that's just how the formula works. But your interpretation there is correct. Any other questions, either in the chat or in the questions and answer Q&A section?
There's what is CMS looking at to determine the largest class in year 5? Is it simply approved positions or claimed FTE on the IRS report for each level?
Yeah, good question, Will. So from our experience, we look at it to see, we kind of compare both, for lack of a better word. So, but it's really the number of individuals matched in that program. So, for example, if we had, we'll go back to the general surgery example. If we had 5 residents per year in that program, and they had to do an FTE out for transplant and pediatric surgery, we're not going to get necessarily less because those aren't going to be on the hospital's IRIS report. We're still going to get the full 5 allowable positions for that program. As Kauser talked about, then we have the second step in the process. So for a 5 resident per year general surgery program, assuming we have all the positions filled, we get 25 CAP. That CAP is then distributed in the second step of the process on a percentage basis over the full 5 years of training as to where that CAP will go. So if they did 20% of their training at another site, the main hospital would ultimately get 20 positions of funding, and that other site would get 5 positions of funding moving forward. So, so it's more so approved positions, but when you say IRIS report, if we're looking at an all-in IRIS report that includes kind of the entire program and out rotations, we would use a little bit of both, but for the main part is they need to be filled into those various positions.
A question from Kevin in the chat.
Oh, it's loading, 1 second.
Yeah, I can read it to you.
Yeah, go ahead.
You got it. For a new program with first year partially filled, the first year with 8, second year with 12, how does that affect the CAP for a 3-year internal medicine program approved for 13 per year?
Yeah, as long as you have in the 5th year 1 full class that's filled, you should be good to go. So even if you have a little bit of stumbling getting the program started, didn't fully fill, or went into the SOAP and didn't fill those positions, you can have kind of slip ups in even 1 through 4 years, for example, as long as in that 5th year of CAP development, you have 1 PGY level that has the full number of trainees in it, and then you would be awarded your full CAP.
Yeah, I would say like even those first couple years don't really matter because those residents that start, for example, like in the 2nd year, by the 5th year, they're going to be graduated out. So that they really don't matter in the beginning. So you have room to build your class up to full complement. I don't see any other questions.
The last chance. Any final questions for Kauser or Scott? Well, thank you to our presenters for the information and insights presented today. In wrapping up our session, we want to thank all of you for participating. As noted earlier, you'll receive an email this afternoon with a short survey to complete, as well as a copy of the presentation. If you have any outstanding questions after today's presentation, please email Hunter Rich at hrich@germane-solutions.com. For your additional educational information, please know that our next webinar will occur this summer. Details and registration for this upcoming webinar will be found on LinkedIn and on our website. Our marketing team will ensure that every participant in this webinar receives an email containing the sign-up link for the upcoming webinar. To be included in any important future announcements, follow Germane Solutions on LinkedIn or contact us on the website. Thank you again for your participation in today's webinar.